but our staff who've all worked so very hard on this program, our planning committee, Mark Johnson in our office, Barbara Giles, she's the person you see outside to fill out your little slips for the door prizes, Joe Zapata, and from the VA, Elizabeth Packer, Veronica Salazar, and Tressa Carr. And in the back of the room, we have a stream team. This conference and tomorrow's conference are being streamed live on the internet to other folks who are listening in who couldn't be here, and that team's led by Bob Merrill, and back there with him as well are John Munoz and Kelvin Buchanan. So thanks to them. And do you want to do? Okay. So
they've slipped out. Got it. Well.
I don't have anything to say, but I'll stand by you.
So we'll introduce Dr. Lillian Oakes, and if Dr. Liliana, sorry, if Dr. shows up, he'll transition into that presentation. And I'm really excited about this presentation.
Why are you excited?
Because I've got some great fall jokes for this one. You want to hear them?
Yeah.
Oh, okay,
yeah,
okay.
I wanna hear it.
So how do you fix a broken pumpkin?
How?
With a pumpkin patch. And what's the ratio of a pumpkin's circumference to its diameter?
I don't know.
Pumpkin pie.
Okay, Russell. It's not about fall. It's not about autumn. It's about fall risk, reduction of fall risks.
Gotcha. Okay.
As he falls.
No wonder those jokes fell flat. Dr. Liliana Oakes received her medical degree from the National University of Colombia in Bogota. She's completed her residency in geriatrics at the University of Texas Health Science Center, San Antonio. She's board certified both in family medicine and geriatric medicine. She's currently the director for Buena Vida Nursing Center and is currently the Geriatrics Fellowship co-director at the university. Dr. Oates has been listed as the best doctor in America and San Antonio, and standing in for Dr. Sa, Dr. Oakes.
Good morning, everyone. So, as you hear, Dr. Sa, we couldn't find him, but I'm pretty sure I wish he will show up in some point, so I will transition to him. I can do this presentation because I'm a geriatrician. So geriatricians should know about falls, right? I didn't make the slides, so we're going to be in a little bit in a journey and see how I walk you through. I just review them in 2 minutes, so let's see how it goes. This is not on, see, so how loud I am. So we're going to try to look into the general data, right? Why we need to spend time talking about falls in long-term care in hospitals. We need to talk about the consequences, review ways to identify, especially interprofessional strategies to decrease them, and areas of research that are important. How many of you work in hospitals? Okay, how many of you work in nursing homes, ambulatory care settings, or hospices, home health agencies? So we have a good group where falls are a common denominator. Doesn't matter what you do, what area you work in, you will be in a care plan meeting if a patient falls. What I would love to see is that all of us involved in processes before people fall. And I think that's the new, you will be hearing, especially in the afternoon, the new culture of models of care is, can we think in teams before falls or other geriatric syndromes happen so we can prevent them? So let us wake up, and there is a first question. Which of the following statements regarding falls in older adults is false? You see that little capital thing? False. So think about what is wrong. A, 1/3 of older adults age 65 and older fall each year. B, falls are the leading cause of injury in older adults. C, almost half of fatal falls in older adults result from traumatic brain injury. D, death rates from falls have decreased over the past decade. So, ting, 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 ting. Okay, we have a D. Who else? False. B's and D's. So D, death rates from falls have decreased over the past decade. Isn't it that sad? You wish that it will be no falls, but it is. So falls in general are very common. A third of people age 65 and older fall each year. That little pearl there means you need to ask them systematically when you talk to them in your clinics. You need to ask, have you fallen in the past 2 weeks? But not only that, have you fallen in the past 6 months or a year? Some older people think that falling is part of getting old. So if you don't ask them, they won't tell you. Falls are the leading cause of injury and death, and that's huge, especially in frail elders when they are taking Coumadin, where they have other comorbidities. The death can happen and nobody will find them. So again, another pearl is we need more technology, and there are systems like the Med Alerts, and there are systems where there are sensors in some of the long-term care facilities where technology around are going to notify somebody. So, but it still is huge. And 46% of fatal fall result from traumatic brain injury, so a head injury related with that. That is bad news because I don't know if you have seen, but if you're going to fall, the first reflex that you do is put your hands in front. So when you see somebody with a facial bruise or an elder that has other injuries, it's because they have lost their reflexes and they're not putting their hands. And that can show also other comorbidities such as weakness, neurological impairments, dementia, where those protective reflexes are gone. Fear of falling among the most common concerns. That's one of the major issues in rehab facilities or skilled facilities is nobody after a big fall wants to walk. So it's really hard to rehab them because they wanted to be in the wheelchair. They feel safe in the wheelchair. So that's a challenge for interprofessional teams to really make safe environments and to work with the older adults and their families. But that's a very common, no kidding, if I fell down, I'm going to be cautious and more careful even if you are not an older adult. So who is at risk for the death? 82% of all deaths were in those 65 and older, so if you are elderly. Men are more likely to die from a fall, 46% higher death rate in men than women. We don't know specifically, and there is not enough, that's an area of research that will be interesting to do. Now, we know that older whites are 2.5 more likely to die from falls compared to blacks, and that's because of osteoporosis risk. So we know ethnicity plays a role. African Americans have a better bone health than Caucasians. Also, if you are thinner, you are a female, you are postmenopausal, you are petite, your osteoporosis risk is higher. So there is an ethnicity component that could explain that data here. That's what I said in the last one. Older non-Hispanics have higher rates of fatal falls due to likely the osteoporosis related with their ethnicity. Rate of fall injury increases with age. So the older than you get, not only you're at risk if you're 65 and older, but if you are a frail octogenarian, due to the comorbidities, you are 4 times more likely to have a fatal injury. So again, prevention and interprofessional team care that can look into the risk factors in these elders are important, including age. Women more than men due to the osteoporosis risk factors. Rates of fall-related fractures among older women are more than double than men. And again, those are related with osteoporosis risk factors. So this slide is to tell you that due to the changes in quality improvement and the healthcare costs associated with events that can be preventable, this is likely to be a major discussion in your hospitals, in your rehab facilities, in your nursing homes. Why? Because we know that many of the falls that result in injury can be preventable. And it's necessary that institutions have processes in place to prevent that an elder get killed because something could have been prevented. And everything is related with saving and cost. And this afternoon, when we talk about the ACE unit with Dr. Parker, he will tell you specifically some models of care we have been able to do in the ACE unit that are saving costs. Every time that you do not have a fall in your hospital and you avoid a hip fracture, not only you are serving that older adult, but you are saving costs to Medicare and prolonged hospitalization. And as we will review, every time an older adult has a major injury, chances that they need to end up in a long-term care place are higher. Raise your hand if you wanted to be in a nursing home. Yeah, I never have found anybody raising their hand. Why? Because you don't want it to be. Those places are necessary. They are important. They play a role. But if we can do everything to maintain them, active and in their communities, that's a very important goal to keep in mind. Question number 2, which of the following statements about falls in the hospital is false? So keywords, hospital, keyword false. A, 90% of hip fractures result from falls. About half of falls result in injuries requiring inpatient care. Reduction in hospital falls is a national patient safety goal. D, more than twice as many hospital falls occur while transferring and rather than falling out of bed. Dun, 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 dun. So we have some C's, some B's. So B, half of the fall result in injury requiring patient care. Hip fractures are among the most common reasons for admissions in older adults. 281,000 hospital admissions in people age 65 and older, 90% are hip fracture result from falls. The reduction of falls in the hospital is definitely a goal. Not only for them, for everybody. We don't want them getting a fall. Based on recent data, a fall in the hospital adds around 6 more days of length of stay. Any of your case managers saying you love to track length of stay for doctors? What a nightmare, right? And that's something that you as head nurses and interprofessional teams and people in administration look into it. So prevention of these older adults and falls and complication after the fall are a priority everywhere right now. Only 10% of fall results in a soft tissue injury or fracture requiring inpatient care. Only 5% of those falls result in major injury. But when those happen, they are pretty bad. Most falls occur while a patient was transferring. That's a very common. So another pearl in this slide is, are you training all your personnel to do transfers? This is not anymore a business of a nurse or a CNA. It's teaching the families when they are in the room, if they are going to provide care to their loved one, how to perform a safe transfer. Or restorative aid in the ACE unit in the medical center works very closely with families to tell them what is an appropriate transfer and what is an inappropriate transfer. When the physical therapists come to the room, they talk to the families how they can help. The CNAs, the physicians, every time I work with the OTPTs, I always learn a new technique or a new thing that is helpful. Why? Because sometimes when I'm rounding, the patient needs to be transferred. They want that I moved in, they're tired, and I don't like to say, no, I'm busy, let me call somebody. I should be able to provide that care on site. So all the personnel, physicians, fellows, trainees, nurses, CNAs, have an investment in how to transfer safely and how to educate the teams around. So let us look a little bit also in some other data. Usually in the hospital, the mid-ages 60s, geriatric medicine and neurology tend to have the highest fall rates at the hospital. Why do you think they have the highest rates? They have the highest admission rates. The high admission rates. What else? I'm sorry? Medications. So they are probably more complex. They are taking multiple medications. What else? So neurology carries what kind of patients usually? Yeah, a complicated patient. Dementia, Parkinson's, movement disorders. So you have the ones that have a very long checklist of comorbidities. So again, so these units in our geriatric unit, again, we will show you more the data in the, later on in the quality improvement session in the part of the ACE. We used to have the highest rate in the hospital. And we were able, by changing certain systems, to have up to 170 days without falls in the ACE unit. It took a lot of interprofessional approaches. So just be aware of what area are you. Are you in a hospital, ambulatory setting? Track, learn to track numbers. Do root case analysis in your patients when they're falling. Find out what processes and quality improvement you need to implement. But get to know what are your major problems, not only falls, but are you having a high rate of delirium? What about your pain, incontinence? What about issues in terms of utilization of resources, people that maybe you are assuming they're doing well, but they are not. And again, managing data is very helpful in terms of outcomes. Okay, many falls are unassisted and occur in the patient's room. Very common also in the nursing homes. The patient is cognitively impaired, they are frail, they want to toilet, they don't remember to use their assistant devices, they attempt to do something and they fall. So it's very common that this happen. We in our nursing home track systematically those things and try to see patterns on holes. And sometimes you can determine that the assistant is not be given in certain holes. So again, how you modify the system approach to address those issues. Most falls occur in evening and overnight. Half of them are elimination related. So the nighttime is very interesting. There is a component of sundowning in many older adults. It's the time where if you have somebody with a large prostate, you want it to pee because your prostate is enlarged, so there is more frequency. There are also inappropriate use of hypnotics, where there is clear data that when we use things like any hypnotic, from Ambien, Lunesta, Sonata, whatever it is your favorite drug, all of those drugs plus benzos plus psychotropics can make people confused. So again, there is a lot. It's a multifactorial issue, and nights tend to be very problematic. Another question. Which of the following statements regarding falls in long-term care is true? So keywords, long-term care, and the word true. A, those age 65 and 74, that is 4 times more likely in a long-term care setting than at home. Falls in all nursing homes have been publicly reported by CMS for the past 10 years. What are true? Neither are true. Dun, 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 do, 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 do. See? See? Anybody else? So in those age 75 and 74, that is 4 more times more likely in a long-term care setting and at home. People, let us look into the data in long-term care. People age 75 and older are 4 to 5 times more likely than those younger, that group 65 to 70, to be admitted in a long-term care for a year or longer. Up to 1 in 4 adults who were living independently before having a hip fracture remain in a nursing home. So again, it's also a subclass of selected patients. They're going to be sicker. That's the reason they're in a long-term care, right? Nobody could care for them. They are likely to use more medications. They are likely to be moving but not very stable. They are in that transition from becoming active to maybe become bedbound due to progressive disorders, usually dementia. 80% of my facility has dementia. Men are more likely to be institutionalized after hip fracture than women. Don't know specifically why, but it will be interesting to look into that. Falls are an indicator of quality care. So this is what we're calling the never events. So there are instances where in the past, if a patient broke the hip, people did their processes, root cause analysis, put things in change. But since 2008, when the never events came, and people are looking systematically and are we really doing everything to prevent the fall, this has become a major issue. Why? Because if now you have an older adult in your institutions, either long-term care or hospital, if they fall and the investigation result that that was an avoidable fall, somebody is not going to get paid, or the nursing home or the hospital. So your documentation has increased. You needed to be more proactive now in teams to really look systematically into those cases, track the data, get discussions with the administration about resources. So we're using a lot of technology in our ACE unit. We use bells, we use alarms, we use bed alarms that you can record the family voice so the patient can recognize when they're moving. We're looking into reorganizing how we round with those patients, so we don't do any more nursing rounds in the nurse's station. They're rounding with the cows, with the computers on wheels in the room with the patient. So the exposure of face-to-face, isn't it that cute name, cows? Moo. So yeah, computers on wheels. So you are moving your team next to the family. We're educating more proactively families in what I mentioned to you, how to transfer them safely, how to recognize early signs of confusion. Again, it's a whole team approach that is rethinking the way that we are trying to view falls now in several systems. 5% of adults age 65 and older live in nursing home, but account of 20% of the deaths. Again, these are complex systems. And again, the resources, we're living it with Texas. Medicaid is cutting resources, so many facilities are having much more workload with their CNAs. And so the statistics are tough for long-term care. If you work in a long-term care, my heart is with you. Well, my heart is with me too because I work in one, but the issue is very challenging. When I sit in those meetings as a medical director, we're all the time providing the best care with few resources year after year, right? And it doesn't matter if you have less money. When you get your visits with the state or you get a family member angry at you, you cannot say, I have less money now. The expectation is there. So I think I take that as an opportunity. Can we rethink the way that we're providing long-term care services? Do we have a role to engage families a little bit better? Do we need to start rethinking how we work with architects, and we actually do it with the UTHSCSA team? The new architect students develop around 12 hours of their training in how to develop smart homes for older people. So we, the geriatricians, go and work with the architects, and it's amazing what the future will look. Because you need to think about, do I build houses that are 2 stories? And if you are in that age where you have knee problems, don't raise your hand, but I know who I'm talking about. It's really hard to climb stairs, right? And how do you rethink things when your cognition is not good? How you're not going to burn yourself? How you're going to connect with telehealth with your physicians, you know? So can you envision gigantic iPhones in the walls that you could actually play with to communicate? So it's here, it's coming. And technology related with falls, reminding older adults, please don't get up from the bed when the sensor hears that. So I'm a big advocate of technology. The cars are doing it now. Did you hear NPR yesterday? Cars that can be drive by themselves in a computer in California. The law just passed. Imagine that. Right now you can buy a very expensive car and you will prevent an accident because it will let you know or brake without you noticing. So again, I think with an aging population that requires and is very frail, we have a lot of challenges that we need to deal with. Let's see, all of these we talk and talk, so I think that the slide here wanted to portray that there is a lot of other things that come for falling that are not just physical. It's an issue of loneliness. When you become more dependent, even if you're already in the nursing home, it's really hard for them. So we're talking about spiritual issues, emotional pain. So let us don't forget that falls not only have a physical component, but they have so many other things that's the reason we need teams from different disciplines working and addressing how you maintain the dignity as after a hip fracture or a patient that is not able to walk anymore. Or after the patient have made the decision to do not walk anymore. I have a lady that could walk, and I said, well, why we don't do some exercise and physical therapy, and I think you can get out of the wheelchair. And she said, Dr. Oaks, I'm 80 years old. I'm done with that walking business. And I needed to accept that. I said, I don't have a good answer for you. If you wanted to choose to don't walk and you say you walk for 85, I mean, what else I'm going to answer? So once in a while, you have them, and it's autonomy, right? They can choose if they wanted to walk or not. Very hard for me. I'm a geriatrician, I want them walking. Well, not all the time. So this is just to say that there is a component, the way that I teach this for the learners is when people are falling, there are things that intrinsic to you maybe are making you fall. So everybody mention things that in your body can make you fall. I'm sorry? Weak ankles. Thank you, I'm deaf. So that's hearing too. I wanted to teach hearing impairment, so good. Weak ankles, right? If you have very poor endurance and strength in your ankles make you, for that matter, weakness everywhere, right? What else? High heels, so you're talking about environmental things. You choose to wear your cute high heel, let's see. Okay, so weakness, what else can make you fall from your body? Dizziness, so a lot of neurological things. Very good. What else? Medications. What else? Parkinson's. Ear infections or vestibular things and equilibrium. So the way that you will do it in your care plan is right, that people is start looking into every single order in your organs this way, and you will find something that can make you fall. From neurological things, visual, hearing. If you have pain in your neck, swallowing difficulties, osteoporosis, you go down, cardiovascular stuff, heart attacks, arrhythmias, right? If you're having diarrhea and leakage, how many of our elders having diarrhea and they are incontinent and they sleep on their urine or feces and break their hip? So then the weakness, et cetera, reflexes. So there is a lot of things that when we work in teams trying to address, and your MDS and the nursing home try to help you and guide you on how to look into those risk factors. Now the environment. So you mentioned high heels. What other are common things in our environment that make people fall? Rugs, right? Especially if you like beautiful collection of rugs, sometimes they can be dangerous. What else? Animals, the cats, the dogs, and they are kind of family members, so it's not like you can say, you know, take away the cat or the dog. So you need to figure out other creative ways to manage pets. Very good. What else? Extension cords. At the hospital, what do we put on people that make them fall? Restraints, follies, IVs, SCDs. So don't forget that a lot of things that we do in hospitals are going to increase the risk of fall. If you are trained in the all ages, which none of you are, all of you are so young and wonderful, remember that restraints make you fall, and that's a misconception. We think that because when we tie people, they're not going to move, they're not going to fall. It's not true. The agitation that is produced by the restraint will make them trying to crawl around the bed, trying to crawl around whatever restraint you use, or slide down. I'm glad we don't have pulse vests anywhere, but they asphyxiate patients, right? So again, the best thing is do not restrain. Go over about other alternatives and develop protocols where all of you as a team have ways to manage this creatively. Medication, some of you are mentioning all of that. So pretty much anything that crosses the brain barrier, especially psychotropics, benzodiazepines, antidepressants. Many people don't think about antidepressants being a big cause of fall. Well, they are. Certain agents that are used for high blood pressure, if they have a central effect like clonidine, can make you fall. And benzos are probably the highest, around 28 times more likely to produce a fall than any other of the medications. Diuretics. So again, antihistamines. We do not use Benadryl. Opioids. So basically what I tell anybody is be cautious. Whatever you put, look into interactions, work in your team. Do we really need to add this medication? What else can we stop? Because you need to think about the implications of medications, not only in falls, but in any geriatric syndrome you may deal with. Other causes are difficulty in transferring, poor food care. How many of you check even your own feet frequently? It's okay, don't raise your hand. Well, some of you raise it, good for you. It's very neglected. So we geriatricians make a lot of emphasis not only to examine the heart and the lung, but remove your shoes. Let me check your shoes. So even you don't need to be a doctor to do that. You can just look into the shoes of your patients and see if they are comfortable, if they are thick, if they are having issues. Maybe the gait, it can show you how they are wore off in certain areas. I will tell you an important issue in patient care, and you will always remember this. Have a dementia lady, she was 75 years old, cared by her son, Hispanic family. You know, she got dementia, ambulatory. She did her activities of daily living okay, but couldn't do anything else. And the visit was, my mom stopped walking. No new medications, nothing new in the environment. She just stopped walking. And the son was really concerned, of course. So we did a very good physical exam, and as a good clinician we are, I told her remove the shoes. Her nails were so long under that they were pressing, and because he's a male caregiver, he didn't, you know, as a son, you don't check your mom's feet. He didn't did any perineal care. It was very difficult. Well, the treatment trimmed them, and she started walking again. Great, simple intervention, right? So we find in our offices a lot of surprises in their feet. So check the feet of patients, especially because you can give all of these multidisciplinary components, but if they're having pain because they have bunions or they have calluses, they are going to fall and so examine those feet. Shoes, no kidding. Have you seen the new shoes for women? It's unbelievable. I think they're cute, but I don't know who can wear those. And I just think fashion is crazy, crazy, crazy. If you are a PT or T in the room, raise your hand. Okay, we have one. We see these once in a while. The family went to a garage sale and bought mom a walker, except that it was for a 6-foot-tall guy, so the little lady. So do that diagnosis in the grocery store. You check the patients, and sometimes I'm gonna say, that cane, go to the doctor's a little bit too high. They're very proud, but the cane is in the room. So check, because those assistant devices that are inappropriate can make you fall, right? So we think they're good. Of course they are good, but if they are, yes. But they are cute. Little ladies, old ladies love them. So again, you need to, again, educate the family. And I'm glad our family usually asks us, we wanted to get, mom is tired, can we get one? So you need to see with the family, do an evaluation, and see if the other things, including her cognition and her ability to compensate in case they start moving too fast, can she really control them? And sometimes we're able to say, no, that's not the best assisting device, let us use something else. But they sell it everywhere, so we see it all the time. Somebody has a question or a comment? So she made a very good point, weather. We are in a very, very hot weather, and elderly patients can get dehydrated very easily. Usually it will take hours for a young person. An older adult can do gardening for a couple of hours. They are old, they don't feel thirsty, they have a chronic fluid intake, and then with the medications that we give them, they can pass out. And I have seen cases with that, and we admit in days once in a while with dehydration. So paying attention to environmental things. If your loved one is going to be doing gardening, getting outside, is somebody going to be close to them? Is somebody going to provide fluid intake? Mark, 15 minutes. See, I can talk and talk and talk. That's bad. So let's see what we can do. What is the data there? And Dr. Sa didn't show up. So I will just keep going, right? Keep going. Okay. Various fall predictions have been developed. So these are just tools that have research on. Are you familiar with the Morse Falls scale? Okay, good. Well, we will learn a few things today. So the idea is you need to develop tools for different reasons and use the tools for different reasons. One, to have a common language among team professionals. So when I mention an scoring, you are working in the hospital or you are working in the long-term care, if you use a tool, and this is just one of the many tools available for falls, people know the same language. What are you looking into it? Second, for research, right? And third, for intervention. You wanted to see if your interventions improve over time. So the Morse Falls scale is very well known. It's one of the most used. We use it in the ACE unit. And it looks into many of the things that we have been working in the past 45 minutes together. There is a history of falling. We know that when somebody has fallen before, they're going to be at higher risk to fall again. So just knowing if they have fallen give you already a risk factor there. Are there any other secondary diagnoses? So things that we already discussed could predispose for falls. Are they using ambulatory aids or things that are already showing that you have some difficulties? Are they having any IV access? What is their gait and their mental status? And then based on the score, the higher the score, the more chances you are going to fall. So it sounds reasonable, right? The problem is everybody that is admitted in our hospitals is going to be likely high risk if you are old. So we needed to, and we invite processes, your hospital, your nursing home, your institutions, to really make that appropriate to your needs and really look into what are you going to do to differentiate between your very high risk for the ones that really can't fall. And again, Dr. Parker will mention in our second hour of the ACE unit, the quality improvement, and get you in more detail how we did that. Question 4. Which of the following statements regarding fall preventions in the hospital is false? So keyword hospital, keyword false. Falls in the hospital are often a result of medical errors. Multifactorial interventions can reduce the fall rate and risk of falling in the hospital. Exercise programs are effective in reducing fall risk in the hospital. Tun, 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 tun. So we have an A. Yes. So Sharon Inouye developed all the delirium protocol and the health program, Hospitalized Life program for the elderly for delirium. And she mentioned a quote that I think is very important. Falls are often the result not of medical errors, but the complexity attached to that. So we just learned that it's everything together what make you fall. And it will be unfair to say hospitals are guilty or nursing homes are, when the complexity is beyond a medical error. So there is debate, and Mary Tinetti, who is the largest geriatrician in the nation and the world doing research in falls, and she developed a tool called the Tinettian balance, which is very highly used, especially in geriatric neurology and training to differentiate patients that have really abnormal gaits from people that are ambulating normally. We'll agree with this. It has been really hard to come with a guideline or a recipe that you could say, well, if I do A, B, C, D, patients are not going to fall. Why? Because the complexity. Now, in the same discussion, the importance is we need to do those. And for certain settings, there are things that will work better than in others. And the important pearl from today is whatever you do in your institutions, you need to look into rate of falls, do quality improvement processes that can allow you to raise what are your problems. Problems that maybe can be in the same hospital. Maybe in my ACE unit I have this problem, but if I go 2 floors upstairs, they maybe have a different problem. So falls require an individualized taking in how you're going to understand the data and make processes around that can make you effective. What we know in the hospital is there are some multifactorial interventions that can reduce the falls. And what those programs are is building in the team, reviewing the medication systematically, doing the rounds, doing some component of mobility, safe mobility, and let's see, I will leave this for Dr. Parker to go in detail so you can stay after lunch. I will force you to stay after lunch. Okay, so this is the data. We were able to do something really cool there, but again, we're going to do, he's going to tell you more about that. Whoops, I give you the answer. Which of the following statement regarding fall prevention in long-term care settings is false? I already did an exercise pro. The issue with exercise in older adults in long-term cares are really challenging due to the cognition and the high rate of, how you call that, attrition, when you don't do it anymore? Did I use the right word? Thank you. I learned that word last week. So when people don't want to do it, they get tired, right? So they drop. So you read about Tai Chi. Have you seen in the news Tai Chi? Tai Chi is a phenomenal exercise for older adults. The problem is in long-term cares, they maybe come twice, they will drop later. So again, whatever you do in the long-term care is going to be harder due to the complexity of those patients. Now, do we do other things? Sure, you need to be culturally competent. There are people that are not going to do Tai Chi. Doesn't matter if you look like Kung Fu. No, you are not going to do Tai Chi. And so you need to find out other things, right? So you need to be culturally competent. So maybe in some places dancing, right? Hispanics like to dance. So there are programs where music and dance have been used to strengthen and lower extremity, decrease depression. Music in general has a fabulous effect in all domains. This is very interesting. Hip protectors in 2003 in the New England Journal came and we thought, man, this is great. I was, in 2003, a second-year geriatric fellow. I went to the national meeting and I met this physician that created them. He was 80 years old, and you could see the video where he's walking in the gait strip, and you could see him falling with his hip protectors. Do you know what a hip protector is? So some of you don't. Do we have internet access? Oh, I will show you a picture. So just imagine I have a boxer underwear and I have two foams that are similar to the NASA fabric that are memory, that they have memory in. And they used to cost around $150 in those days. Now you can buy a pair for $39.99. And what the data show in 2003 is by wearing those boxers with those, you couldn't see it on him. I mean, there wasn't any issue of looking like a tank or anything. It looks pretty good, You could reduce your hip fracture up to 60%, meaning 10 times, well, yeah, you have your smartphones, just Google hip protectors, check images, and you will see them there. Thank you, good idea. So the problem is compliance. Only 42% of people wear them. So great invention, but compliance is a big issue. Vitamin D supplementation, especially high-risk populations, people in long-term care, they don't get enough sun, they have probably chronic issues and malabsorption, so there is data that replacing that, there is enough epidemiological data to support the replacement will reduce falls. And the multifactor intervention may reduce falls. Again, we have been able to show in our quality improvement that it did, and we will show you later. So how is my time going, Mark? 8 minutes, okay. So what I just mentioned, there is a cost analysis that if you could implement them, they will save money because they work. It's just how you convince that little old lady and old man to really wear them every day. But there is data, you know, it's here. You will save $136 million the first year if you have 3 pairs. And what you usually do is the foam is one foam, but you have 3 pairs of underwear so people change. But again, the implementation of that, I do it all the time in my visits for people that high-risk fallers. I give them the printing information. I can tell you probably 2 of my patients in my panel really have followed through that. Now, we think that if Medicare will pay for those, maybe just the fact that they get paid, but again, there is not enough data to support that yet. But again, if you have a relative and somebody that really wants to use them, there is definitely a place for that protector. So let us close with a case briefly. You have an 84-year-old lady presenting to the ER with worsening right hip pain and headache after a fall. Fell a few hours ago in her assisted living on the way to the bathroom. She says she was walking and then suddenly the right knee gave away. Medications, she's taking amiodarone, warfarin, metoprolol, lisinopril, simvastatin, tolterodine, hydrocodone, naproxenasprin, glucosamide. Those are the ones that she remembers she's taking. If you probably go and check her bedside, you will find all their surprises there. She's allergic to sulfa. She got a history of atrial fibrillation, that's the reason she's in warfarin. Hypertension, so if you are not a physician or clinician, that's the reason you take metoprolol, lisinopril. Simvastatin is a cholesterol pill. Tolterodine is for your incontinence. Then painkillers, pain stuff. Hearing loss and history of falls. She got some surgeries there, pretty, common, no big things. She got family history of some heart disease, strokes. She lives independently in AL, has 2 children. They do not live in Texas. They're out of state. And she is very dizzy, constipated, has urinary frequency, right pain. What are your concerns? So she's really concerned that she's taking too many pills for pain. What is the frequency that she takes those? What is her pain scale? Are those on PRN or she's taking all of this at once? Very good. What else? Yes? Exactly, we didn't mention any alcohol history, but we maybe didn't ask it, but what is she drinking? I actually have a patient that her son worked in Budweiser. That refrigerator didn't have water, but had a lot of Budweiser. And she was very demented and confused. She was drinking 8 beers a day. She was living by herself. He came at night, and I did a home visit. If she would have come into my office, I would have done a mega workup, do everything, and never figure out it was a drinking issue. Very good. So an unmasked drinking problem. What else are you concerned about her? Yes? So she got an injury, right? I mean, she's in blood thinners, and we reviewed that she may have had a major injury there. Very good. What else? 2 blood pressure medicines. So is she being orthostatic, meaning are we giving her too much medication and now she's feeling dizzy because maybe when she's sitting down, her blood pressure is high, but when you stand her up, the blood pressure drops. So the pearl is never treat sitting blood pressures. Always stand up your older adults. That's a huge common mistake. The cardiologists come, the blood pressure is high, they increase the medication. We need to be advocates. We tell the cardiologist, did you check the orthostatic? She's already dropping 50 points. We cannot add more medication. So again, that's huge. What else? She got history of falls, so finding out if she's in assisted living, can we get more history? Why she's falling? There were environmental things, or she was having already issues. Very good. Somebody else said something? So the incontinence, is she leaking a lot? Is she sleeping on her, sleeping in her urine? So very good. Let's see, I think for the purpose of time, all of you did a fabulous job. So the effect, we think that using more Nintendo and again, computerized systems that can be interactive, maybe play a role. We have a Wii in our nursing home, and it's amazing how you can do just even restorative by doing boxing and pretending playing tennis. So again, can we become creative? What will be the role of technology? We talk about motion detection systems. And the idea is that, again, more nursing homes, quality improvement programs. Create your little huddles or meetings, or use more effectively your interprofessional team meetings to look into that. And you have some resources there. 1 or 2 reactions or comments before I think we eat now, right? Okay, so no questions or comments. No, just kidding. Anybody wants to mention something, share something that you are doing proudly, please. This is not only about us telling you good things. Any of you wanted to share a good story or something that you are doing good in your institution that is working? Don't be shy. Yes. You are so sweet. Very kind, thank you. Well, you did very good job by being flexible and answering a lot of questions. So thank you, enjoy your lunch, and we'll see you in a little while.